Welcome to our webcast and మీరు మాట్లాడండి. After that, I will start. Ready? Yes. Share link పంపాలి వచ్చిందా? Okay. Okay. Is it okay? Display. Yeah. Yeah, I think you have put something different. You are wait a minute. Open this very well. That play this. మీరు స్టార్ట్ చేస్తారా? ఓకే.
Ready about.
Yeah.
Good evening to all. Today we are welcoming to the webcast on the complex chip osteal heavily calcified lesion in a 80-year-old female. This is a regular program organized by the KIMS Sunshine Hospital. We are regularly doing all this complex for the benefit of all those interventional cardiologists. Now I will hand over to Dr. Sridhar for his comments.
Yeah, good evening to all of you. Today we are going to share one nice case. This is a 80-year-old female patient and a very complex PCA. We thought of discussing about the usefulness of block modification devices and about the IVUS usage. Whether to use some patients, some doctors may use before, some patients may use afterwards. But always when you use the imaging, please do before PCI, during PCI and after that. Block modification. See, adequately it has to be modified. So once you use the imaging, always check whether it is adequately modified or not. Before that, you assess the plaque morphology. Is it calcific, fibrous, or lipid? Based upon that, you can choose the plaque modification device. You also assess the severity of the calcium expansion index. And once you do the plaque modification, whether have you got the adequate fractures or not, luminal gain is there or not, any reverberations. All these features you have to see. Once you encounter all these features, we are very sure that it's adequately modified. Then you can go ahead with the stent implantation. Once you implant the stent, you look for expansion, apposition, and is there any middle edge dissection. So these things you have to, with this brief introduction, let me introduce the case. This is a 85-year-old lady presented with, she is a known diabetic, hypertensive, with a restrictive lung disease, presented with the ACS and STEMI with a recurrent episodes of pulmonary edema. And ECG was normal and except for minimal STT depression, but there are no significant STT changes. Today echo shows normal liver function, ejection fraction 58%. Investigations HB 11.3 grams per deciliter, creatinine 1.36 milligram per deciliter, GFR 40 ml, and RBS 253, and NT-proBNP elevated. You can see NT-proBNP and TRAPI both are elevated. This is the ECG, except for minimal ST depressions, which even many females will have those type of, there are no specific findings on ECG. And now you can see the ECG angiogram pictures. Now I request Dr. Vijay Kumar Reddy to discuss about the angiographic findings.
So this lady has got a left dominant system, has got osteal tight, heavily calcified lesions involving the ostium and the body of the left main disease. So here, and there is a disease in the this thing, proximal LAD also. These are the angiogram, and there is a diffuse disease in the circumflex also. So our plan is to do some plaque modification imaging and image guided patient, and the patient has got a restrictive lung disease. She's a 85-year-old lady and EGFR is low. So there is a high risk the surgical candidate. So planning for PCI.
Surendra, do you want to say something?
Yeah, it is a grade 3 calcium on the plain angiography. So our upfront plan was to go with rotablation because grade 3 means it is a severe calcification and it is also involving LM, osteal LM to proximal LAD. So we have taken upfront strategy of rotablation.
Anything you want to say?
Same.
Kavya, do you want to comment?
Yeah, just that the patient had recurrent episodes of pulmonary edema, so definitely this lesion had to be addressed at the earliest. And of course, angiographically, there is severe calcium, so imaging would further help us guide in our tool of plaque modification to use.
So here is a 85-year-old female with the recurrent episodes of pulmonary edema, and that those episodes were troublesome. And angiogram shows there is a radiolesioncy of the left main, and there is a tight lesion in the proximal LAD. So calcium extending from the left main to LAD. So angiogram shows L6 appears to be fine. The ostium is relatively disease-free and very dominant. Right corner is non-dominant, L6 is dominant. So our plan is to go ahead with provisional stenting from left main to LAD because L6 is a big one, ostium is disease-free. So because of that, we have decided, all of us decided, we'll go with the provisional stenting. So before going for, because she's advanced age, 85-year-old lady, and there's a radiolesioncy in the calcium shadows you are able to see on the angio images before injecting the contrast and seen on both sides of the vessel wall. That itself indicates angiographically it's a severely calcified lesion. So when the severely calcified lesion, naturally they require some kind of a plaque modification device, either rota, orbital, IVL. So which one to choose? Then I will ask Dr. Vijay Kumar Reddy to say a few words about the plaque modification.
So here this needs to be imaged. So what is the ideal image for this? Because our EGFR is very low, so we cannot do OCT. So IVS is the best modality. So this is a osteal location. Osteal location, there are two things. One is the this thing, rota and orbital. Both are the orbital. This thing. Rota is ideal for me in this case because though we cannot do this back cutting, rota we can start the burring from the guide catheter and go in to abrase the ostium of the LMCA.
Anything, Kavya, you want to say something?
So, just that maybe we could also consider mechanical circulatory support at least in the form of an IABP. Considering it's such an osteal lesion and a left dominant system, of course, we would need a temporary pacemaker and maybe consider an IABP also.
Okay. Surendra?
Yes, and as sir said, Vijay sir said ki we'll go for rotablation as it is a osteal LMCA. So rota will give some forward cutting. So we can't use orbital atherectomy because it is osteal. So it is very good decision to go for rotational atherectomy with MCS support, as our colleague said, Dr. Kavya ma'am.
Want to say something? Now, this comes under high risk group. Why? Because one is age, 85 plus, and severe calcification and involving the left main and episodes of acute pulmonary edema. So, patient is requiring definite oxygen support and recurrent episodes of pulmonary edema. So, some kind of IABP, what we thought will give IABP support because LVDP 18. LVDP was 18. So mainly to reduce the afterload. At the same time, put the IABP and simultaneously you keep that because L6 is dominant. If something goes wrong with the L6, patient can go with a complete heart block. So that is the reason we thought of giving a balloon tip pacemaker support. Then take the IVA study and assess the calcium severity. So main intention is to assess the calcium expansion index. So what is the arc of the calcium? Is it 90 degrees or 180 degree, 270 degree or 360 degrees? And depth of the calcium, is it 0.5 or more than 0.5? And what is the length of the calcium? Is it more than 5 mm or not? So based upon that, we wanted to take decision. And if IBUS you are using, calcium nodule also important feature. So now already we have put the temporary pacemaker. This is IABP support. So both before procedure we started because better to keep, because left means some dissection extends into the left circumflex. Chance of going to bradycardia hypertension is very high. So started with IABP 1:1 support. And initially we engaged what kind of catheter we can use here, left main, when the calcium is there.
Usually, when there is osteal LMCA, better not to use AL or XB3 catheters because it can cause the dissection of the osteum. So better to take a JL guide catheter, which is an ideal in a osteal location. Avoid AL, avoid XB3 or UB.
Okay, anything?
No.
So here, usually if the ostium is involved, definitely the first choice is JL because EB or XB can lead to, suddenly it can occlude the ostium, it may lead to dissection. Particularly if there is a critical osteal stenosis, always go with the JL and don't engage fully, just to keep nearer the, if needed, if you can give the side rolls also, just to go to the nearer without engaging, try to enter into the L6 or LAD, whichever it may be. Stabilize the catheter, then you pass the one by one, acquire the IVUS image. Here, the LM ostium appears to be reasonably good. If you see the epicranial, you can see the appears to be reasonably good. There is some reflux. That's the reason we have gone with EBU 7 French because the patient requires some block modification, everything. So if something goes wrong with L6, better to protect, we may convert into the initial, those strategies provisional. If something goes wrong with the, which is very unlikely with the LCX, then we may have to go with a either T-tap or go with a Coulet technique. So our intention is to convert into the Coulet or T-tap if something goes wrong with the side branch. But based upon the angiogram images, which is very unlikely. So already we have placed run through wire. Now LAD lesion, we thought of pre-dilating with 1.5 into 10 mm balloon. So already dilated, say 1.5 into. Now after that, our intention is to take the, so just allow the IVUS catheter and take the images. But surprisingly, we were unable to cross with the IVUS beyond the proximal LAD, where there was a tightest lesion in the proximal LAD. So IVUS catheter could not cross beyond that point. So then what we thought, okay, at least we'll take the, you can see the image very clearly. It is not going beyond the tightest portion of the proximal LAD. Then we took the proximal LAD just before the tight lesion and left main osteal study was done, IVUS study, and it showed very large calcium nodule. So this is a classic uncrossable lesion and large calcium nodule in the left main. So a case with a large calcium nodule and severe calcification of the ostium of the LAD and proximal LAD, and beyond that there is a tight uncrossable lesion. Now what is the strategy? Now you can discuss.
So, calcium nodule is one of the difficult, challenging task in the management of the calcium. If it is a concentric calcium or eccentric calcium, that's okay. But the nodular calcium, there are different ways. One of the ways is rotablation with a extra support wire or orbital atherectomy. They're ideal because it run through and through. throughout the vessel. So modification of the calcium nodule is very essential, and you must assess whether it is a eruptive or non-eruptive calcific nodule also.
Anything you want to add, Surendra?
Yes, as this is the classic case of balloon uncrossable lesion, and also in IVA study there is a calcific nodule. So these two parameters, these two lesions, these characteristics will give idea that we should go for rotablation, because rotablation will nicely ablate the calcific nodule and it will create more acute luminal gain, because by cutting we can't get enough acute lumen gun, or we can't ablate the calcium. So it was a very good decision to go ahead with rotablation. Yes.
So here, uncrossable lesion with a large calcium nodule in the left main. And if you see, the calcium is also extending from the aorta, from the ascending aorta into the left main. So here we should be very careful about the guide catheter. What happens sometimes when pushed, it may cause dissection and acute closure of the, because the calcium is there. So you have to be very, very careful. Now we are showing the IVUS image. You can see very clearly, this is just proximal to the tightest lesion. Now you can see the calcium mark, but here lumen appears to be reasonably good. This is the LAD ostium, where thickness is almost more than 1 mm. You can see the calcium, nodule you can see, very large calcific nodule. See, it's like a hillock. You can see almost occupying the 50% of the left main area. Very significant calcium, very large chunk of the calcium nodule projecting into the left main, mainly in the shaft. So then, because as it is because this case is an uncrossable lesion, when uncrossable lesion, only two options. One is either laser or rota. Classically severe calcium, best option is to go with rota. So rota, what we thought, we'll go with 1.25 bar, create a channel. 1.5 we can go ahead, but the only thing is we were very, because advanced age, LV dysfunction, patient was presented with a recurrent episode of pulmonary edema. More debris going distally, it can lead to slow flow, no flow. That's the reason our intention is to go with these. Each run should be like a 10 to 15 seconds only. Give enough gap, enough interval between the runs. That means almost 15 to 20. And you see that ECG is fine and hemodynamically fine. No evidence of angina, no ischemic features. And in between, give a small dose of contrast and check whether flow is adequate or not. So these are the mandatory for this case, because the calcium nodule, large female with recurrent episodes of pulmonary edema. And in that case, if the slow flow, no flow takes place, it's a catastrophe. That's the reason, even if it takes place, detect early, and during the slow flow, no flow, you are not supposed to do the rotablation. If you stop the rotablation, you anticipate any slow flow, no flow is there. That time you stop burring and give a cocktail. Give a Nipro, give a NTG, adenosine. If really refractory, brady and hypertension, give intracoronary adrenaline and sort out and escalate the inotropes, escalate the IV fluids and sort out that. Once stabilized again, you can go ahead with and now we started the rotablation of the LMCA and LAD. Now this is 1.5 bar, and we have performed with 1,60,000 revolutions per minute and 5 runs, each run 10 to 15 seconds. So after rota, now this is a IVAS run. Any one of you can comment. Now IVAS run we have taken very clearly. It shows some fractures, but in some area there is a the significant burden of the calcium. So calcium. So meanwhile you can discuss.
So here, here we are doing with 1.25 bar. For me, the most dangerous bar is 1.25 bar, because it is a bullet-shaped bar. It goes directly. So in case of while doing rotablation, there are some important points to be noted. So once the rota bar is in the vessel, you should release the tension. If you don't release the tension and push, it will go abruptly and without burring the. So the pecking motion here, most of them they will do rapidly. It is not the correct way. So while advancing should be done slowly and withdrawal should be done very rapidly, slowly, rapidly. That is the way of doing things. So you should give time for the rotablation to burr or to ablate the calcific the lesion. And one more thing, each should not exceed more than 15 seconds, and you should give 30 seconds for the all atheromatous, the calcific debris to be taken away by the this thing blood flow.
Aparaj, you can comment.
In this IVUS pullback, we can see that in proximal LAD there is some luminal gain along with cracks in the calcium. But as we come forward into the osteoproximal LAD, still the 360-degree calcium is there and there is no luminal gain. Even LM calcium nodule was untouched by rota ablation. So we have to go ahead with another, or we have to increase the burr size. So what is the plan?
No, actually, if you see the first, I think you have missed the first IVUS image. First IVUS image is more calcium.
Yes, initially.
What is your observation? Initially, it was more, but it's
comparatively
it's shaved because you have missed the first image. So still there is a reasonably large calcium chunk. But compared to the earlier image, there is a definite shaving of the, there are no bias. It is just nearer the nodule, it ablated, but still because the large area of calcium, as you mentioned very clearly, LAD osteum still very, very tight. Calcium thickness is more. So here, definitely we feel there is the patient requires additional adjunctive device. That is having either you go ahead with additional cutting balloon or go with IVL because the thickness of the calcium is more. So I prefer IVL over the rota. We did only 1.25 bar. You can see definitely this is a shaved. You can see the fractures. You see fractures also you can see shaved. So now we will show the next image. Now what we have planned, now as we planned like a C2 plus 120 IVL balloon. So now the maximum area of calcium, LAD osteum, our target. This is a targeted therapy. See distally not that much calcium and that is relatively shaved and large calcium nodule in the LM. So when you deliver the pulses, you give maximum pulses to the LM as well as the osteoproximal LAD and beyond that you can. So what we did after 120 pulses, we have chosen 3.5 to 12 mm C2 plus IVL balloon, 50 pulses in the LMCA, 40 pulses in the osteoproximal, 30 pulses distal disease segment. So this is our strategy. Anything anybody wants to discuss about the IVL, you can comment or anybody. You want to discuss IVL?
As we successfully ablated the calcific nodule, but there was still superficial calcium was more. The arc was almost more than 270-degree to 360-degree in the most of the area. So IVL is the best strategy to break that superficial calcium and will gain to get again more luminal gain.
Any one of you can add features of IVL. What way it's see, it differs from routine atherectomies like a rota and orbital. Those points you can discuss. You can discuss if you want. Kavya.
So the IVL balloon has the various mechanisms by which it ablates it, by the mechanical, chemical, and the various other compressive forces and the micro bubbles which are formed. It is very useful in cases of calcific nodules. And especially because in rota, we have that worry of wire bias, especially when there is a calcific nodule. So that way it's a little safer when there is a calcific nodule, and it will definitely further help us ablate when it is not modified adequately with other forms. And if the balloon is crossable, of course, we would definitely prefer an IVL in case of calcific nodule.
IVL causes, it generates at least 40 to 50 atmospheres. So high pressure. So because of this sonic waves, it causes fracture of the this calcium.
You want to say anything, Kevin? Okay. Now, the IVL, when compared to rotational atherectomy and orbital atherectomy, there are a few advantages because slow flow, no flow is very low and the dissections are very low because it's a balloon-based strategy. So debris generation is less because whatever fractures are there, that is within the vessel wall. So it will not create debris. So distal embolization less likely, so that the slow flow, no flow is hardly you see. At the same time, dissections are very rare, even perforations are rare. But one of the disadvantages of the IVL balloon, if there is a very large calcium nodule, if it is very, very sharp, it can rupture the IVL balloon. So you may have to use the second IVL balloon. So that is the reason when calcium nodule is there, go to 4 atmosphere, no need to go to 6 and immediately deflate. That you can continue. Or the one of the options when you do the calcium nodule. So though the disrupt studies have shown very clearly, it's also equally effective whether eccentric or concentric calcium, because the calcium nodule also they mentioned very clearly, they observed it's equally effective. But what we feel generally in calcium nodule, we feel rotational atherectomy, orbital atherectomy, definitely it shaves so that luminal gain will be much better. So combination of devices will be more useful. Just now, Dr. Vijay Kumar Reddy highlighted one important point. We have to identify, is it calcium nodule, is it eruptive or non-eruptive? Why? Because eruptive nodule always is soft, most of the time yields well with the routine devices, whereas a non-eruptive is a hard, very difficult to yield. Most of the time, these very difficult to yield with a even regular, requires combination of devices. But the recurrence rate is more with the eruptive calcium nodule, less with the non-eruptive calcium nodules, recurrence rate. And compared to non-calcific lesions will have a, irrespective of best results, they will have a more MACE rate. But always prevent the underexpansion, minimize the malposition as far as possible. If any dissection is, cover it and see that you are covering the entire disease segment. So these are the important points. IVL is the only one which can address the deep calcium, whereas Rota mainly for superficial calcium. When the calcium thickness is more, patient will have a superficial as well as deep calcium. So it can tackle. So initially the superficial calcium was tackled with a Rota. Then we are going with the IVL to ablate the deep calcium, and at the same time it acts against the circumferential calcium because balloon delivers the balloons in all directions. So each microbubble generates 40 to 50 atmospheres with high pressures. It can create a not only macrofractures, it can create a microfracture so that it alters the compliance of the vessel. When the vessel is compliant, with NC you can dilate it and subsequently the stent expansion will be better. So this is after IVL plaque modification. So again, because we know the calcium is very, very thick and the calcium arc is almost circumferential, large calcium nodule, our intention is to do the further aggressive modification before going ahead with stent implantation. So we used the 3.5 into 15 mm NC balloon, almost used 14 to 18 atmosphere, dilated enter LAD and LMCA. So this is now post IVL, post Rota, post NC, we have taken the IVS image. You can interpret, Aparaj.
Coming towards the proximal LAD, we can see there are, this is free zone. So there are branches are coming. So calcium, 190 degree calcium is there here with the fractures and adequate luminal gain is there. So as we are going proximally, again, significant calcium fracture is there at around 6 to 7, in between 6 to 7, and 180 to 270 degree calcium is there, but luminal gain is very good. And even we can see calcium fracture at 1 o'clock and 9 o'clock position. And there is good luminal gain. And we are coming towards the osteal LAD. There also we can see there are significant fractures at 6 o'clock and 12 o'clock position with adequate luminal gain. And we are coming into the LM. You can see that non-active nodule initially it was there, it was well shaped up, and there is good luminal gain in LM. And entire this calcium was shaved off. Good fractures are noted. So we are coming towards the proximal LM, which is disease free.
Sir, you can come.
So for identification of this thing, calcium, which is the IVUS or OCT. IVUS is the better because it can relate well. It can identify the deep calcium also. Whereas with OCT, we cannot identify the deep calcium. We can identify the depth of the calcium, which is not seen with IVUS. So IVUS is definitely a better imaging modality when compared to using calcium.
Anything you want to add? You want to add anything? Yeah.
Sir clearly mentioned we have to adequately decalcify the lesion. We have to modify the calcium very nicely with the rotablation and IVL. Why? And there is a recurrence of the calcific nodule if you don't ablate the calcific nodule. Why? Because after if we put stent without modifying calcium adequately, the drug which is on the stent surface, it will not absorb, it will not go to the intima because of the calcium. So it is very important to ablate the calcium nicely. And in our case also, we have ablated the calcium very nicely with rotablation and IVL. There was very good fractures in the superficial calcium also after IVL.
Now here, if you see the IVUS, if you observe the first initial IVUS study, before plaque modification, there's a large chunk of calcium nodule projecting. But after plaque modification, it's a flattened, almost multiple fractures. See, it's almost disintegrated. You can see here, almost. So this is the beauty of the combination of devices. So the left main area, under expansion definitely will have more bad outcomes because it supplies, if the L6 dominant, almost 80% of the area is supplied by the left system. So in such cases, especially any case with the left main, not to compare with the plaque modification, see that the expansion is adequate. So this is a classic case where the combination of IVL plus rota plus post NC balloon, high pressure inflation, adequately fractured the calcium nodule, deep calcium, and multiple areas of calcium you can see very, very clearly. Now you can see very clearly luminal gain is very good, even angiography views. Previously there was a tight lesion, good antegrade flow. And now what is the plan? Our plan now, the preparation of the lesion is adequate. Now we are going ahead with the stenting. The stent we used 3 into 18 mm Zine Sierra, implanted at 12 to 14 atmosphere, that covering the distal extent of the lesion, and almost 12 to 14 multiple inflation, 2 to 3 inflations. So usually in calcific lesions, we always maintain 15 to 20 minimum seconds inflation, and 2 to 3. Most of the time I give 3 inflations. Why? Because sometimes if you don't adequately inflate, if there is an under expansion, difficult to recross. So that's the reason adequately inflate whatever balloon have, and subsequently you can put the again NC and go with the high pressure inflation. And this is the, again, we went ahead with the provisional stenting of the left main because the L6, now you can see ostium is very well visible and no significant lesion of the ostium. Then we took the 4 into 23 Zine Sierra with only 2 to 3 mm overlap, started from the ostium and covered the overlapping with the distal stent. This is a provisional stenting of the LM bifurcation. And anything you can comment, what type of stent you want to use, and you want to radial strength, any struts, any cell size, anything if you want, you can discuss.
So it's a Medina 110, this classification. So this single stent strategy, provisional stent strategy is the idea. So when you are doing a left main to LED stenting, you should see a stent which can be, usually there is a mismatch between LMC and LED, and you should choose a stent which can be expanded to 4.55, because most of the times our LMC is 4.5 to 5 and LED is around 3 to 3.5. So usually in this scenario we have to choose two classes of drug. One is the Jane's group and another is the Onyx group. The advantage of Jane's group is a fluoropolymer. That is the advantage with the fluoro. The fluoropolymer is advantage, it causes thromboresistance. It binds with albumin. It prevents fibrinogen to come to the stent surface. So there is a thromboresistance. The chance of stent thrombosis is very, very, very unlikely with the Jane's group of drugs. And the left main can be expanded up to 5 and 5.5 also. That is the advantage with the Jane's group of stents.
Anything you want to, anybody? Yes. Yeah.
Though angiographically it is LCX is looking disease free. Sir, would you like to go for IVUS in LCX?
No, when but ideally in left main bifurcation, no?
Left dominant.
You can left dominant system, but really borderline lesion or mild lesion is there, always we do. But here completely clean. So that's the reason we have not considered. But any left main bifurcation, always you have to take the LAD to LM run, LCX to LM run. Mainly, is there any silent disease, anything is there. But it's a big size vessel. I didn't see any osteal, not even 20-30%. That's the reason we avoided doing the LCX. And we are not going to get any additional information. If it's like a 30-40% or 50% lesion, I would have gone. So here, and now the provisional stenting, why we have chosen the designs means one is good radial strength. The microns about 80 to 85 microns, and really that fluoropolymer, and at the same time expansion, the 4 can go up to 5.5. So based upon that good radial strength, calcific lesion, that's the reason we opted for Xens in this patient. So then this is always regarding part. Any one of you can discuss about the part, when to do part and what is the technique of the part. You want to say anything? Yeah, you can discuss part.
So, part is proximal optimization technique. So, whenever we are going even whether provisional or else two-stint strategy, the part is very much important because recrossing will be very easy with after doing the part, because part will open the struts, whichever struts are coming across the LCX, and part will optimize the stent to the proximal vessel, whether it is LM or proximal LAD, whatever may be the proximal vessel. Part will optimize the stent according to the proximal vessel diameter.
You want to say anything? Part?
As correctly said, we have to optimize the proximal part because if any future interventions to avoid first malapposition to get the adequate expansion, and if we need some future intervention also, so our wire will not go abluminally while doing adequate part.
So this is very important. As soon as you finish, put the provisional state, before crossing the side branch, you must perform the part. Otherwise, what happens if you pull the wire and if you recross, it may go abluminally. So one abluminally, even if you push the balloon, it may lead to LSD and stent deformation. At the same, always perform the part, then remove the jailed wire, and subsequently, because it opens these side branch struts nicely, so you can cross the side branch very nicely. And when you do the part balloon should be just before the carina point. Distal marker should be just before the carina point. If you go beyond the carina point, what happens? It crushes the carina toward the side branch, and the side branch carina shift will take place. It can lead to side branch closure, compromise. So that it should be, and at the same time, the proximal, the marker should not extend beyond the proximal border of the stent. Don't come proximal to the stent. So if it is ostomy, they try to pull and do the osteal flaring. So part should be performed, and it should be, when you are using the imaging, see the approximate size of the stent, the LM size, and choose the same. See, one of the advantage of the imaging, you can select the part balloon according to the IVA size. Suppose assume that your 5 mm balloon is there. 5 mm LF size is. You take 5 mm balloon and opposite. Suppose if the 5 mm angiographically you may underestimate, then that time if you take 4.5, still there is a chance of under expansion. So that is the reason precise sizing using the imaging is mandatory, and no need to. Otherwise, if you are initially you are doing 4.5, then if you are running the IVAS, again there may be a malapportion. Then you are forced to take one more balloon. So that also avoids the unnecessary usage of the more and more devices. So one is precise sizing, very important, and see that the distal marker is proximal to the carina point, and proximal marker should not extend beyond this one. These are all the important points. After, once you finish the part balloon, then you remove then put the wire and remove the jailed wire. So sometimes jailed wire may not come. That time, how to do it? Any Kavi, or you can discuss.
So
Jailed wire, removal of the jailed wire.
jailing wire. So jailing wire is very important because if you put manually, it can cause sometimes LSD also. Suppose if you don't, if you are not able to this thing, we can pass a micro catheter up to the tip of this thing, and we can remove with the help of a micro catheter. That's a very, very important. Don't pull there are because it causes LSD.
Anything you want to say? Anything?
No, that's
So if jailed wire, if not coming, please don't apply any force. Sometimes if you apply force, what happens? Again, it lead to LSD. It can causes a longitudinal stent deformation. That time it's very difficult to recross with the device and replacing the wire. So always use the microcatheter, go as deep as possible and pull both microcatheter and wire. Second, that is not going, very low profile balloon pass underneath the stent and try to open and make it a space, and after balloon dilatation it loosens, then you can pull out the wire very easily. So these are the methods, but always you disengage the catheter. When you withdraw the, suppose the wire is stuck, then if you are pulling it, then it can suck the catheter and it can hit the proximal border. That can lead to LSD formation. So these are the important tips. Always control the guide catheter. See that it's not touching the proximal edge of the stent, and especially before part. Especially before part, if you are removing the jailed wire, it may go and hit the proximal border and it can lead to LSD. Once LSD takes place, very difficult to cross most of the time. You have to take ultra profile balloon, dilate it, then bigger balloon, graded dilatation. That's how you have to manage it. So part was done using 4.5 into 8 mm balloon, 12 atmospheres. Now after that, now what are the strategies? Okay. Now you can enumerate, like you want to go with a kissing balloon or different strategies or part side part. Here, the provisional stenting, you can, even now well recommended by the EBC also, European Bifurcation Club recommendations. So either you can go with part side part. This is much more simpler compared to SKS. Just to cross the side branch, just to dilate the side branch struts, then repeat the part. Initial part, put the wire into the side branch and then put the balloon, open just only 3-4 mm extend into the side branch, open the side branch, then perform the repart. So whatever deformed, the struts deformed to take place, it will be rectified with the repart. So the side part, another one after part you can do the kissing, then subsequently again you can do the repart. These are so crossing of the strut, that is important. So where do you want to cross in provisional stenting? Where do you want to cross DK crush? These are the important points. So you can discuss anything.
In decay crush, ideally you should the first crossing should be done in the proximal stent. The second crossings are the mid. Always you should avoid the distal crossing. That is the main thing in a decay crush.
Want to say anything? So, in the provisional stenting, yeah, tell me.
This necessary routine to perform either port side part or hissing? Is it only if it is side branches pinching, then only?
Only side branch pinching is you can do it. Otherwise, not needed. Just to perform part and leave it. That's enough. Only the criteria, if there is side branch compromise, luminosity more than 50%, or if there is an intermediate flow or flow limiting intersection, and such case only, if the patient develops EC changes, if the patient is symptoms and signs of side branch ischemia, that time you can just only 2-3 mm you can extend and do it. Here, why we have done here, though the side branch appears to be fine, sometimes these OCT studies have shown very clearly there may be few studs across the ostium because it's a huge LCX. We don't want to take any risk about the risk of restenosis taking at the ostium of the LCX. That's the reason our intention is take a small balloon, like it's about 3.54 mm vessel. At least take a 3 mm balloon. Once you dilate, what happens? It will not touch the side, the outer, that inner surface of the vessel. So restenosis is less likely, and it will open the studs. So once studs are separated, side branch restenosis is less likely. That's the reason we have extended only to the minimal extent. So here purposefully we have done mainly to avoid any jail studs across the L6 ostium. But provisionally guidelines have not recommended, and at the same time even studies did not any favor. There is no change in the mace rate whether you do it or not. But decay crush always you cross proximally and never cross distally. Once you cross distally, what happens? You crush the segment. Sometimes wire can go beyond the crushed portion, and when you open it, near the carina, there may be a bare area that may lead to restenosis rate. But in always crushed, you cross proximally, open the studs very clearly. Then that is one. The progestin always a distal crossing, never cross proximally. If you cross proximally, the anchoring of the side branch, ostia with the studs are very good. So that is the advantage. Ensure that proximally you are crossing. In the decay crush, second crossing, you can go distal crossing. So these are the important things you have to consider. So then report. So now, again, to maintain the geometry of the left main, because particularly at this confluence area, because you have dilated the 3-4 mm, there may be alteration of the side, the distal LM stent area. So to rectify it, take 4.5, we took again 4.5 into 8 mm NC balloon and dilate up to 12 atmosphere. That also just before the carina only you can do it. So this is a repart, and this is the IVAS run. You can see very clearly the final IVAS run. Mainly, final IVAS run should be done. Why? Because is it expanded well? You have to see, is it expanded well? You can, one of you can comment.
So,
Sir, you see. Yeah.
So in case of this calcific lesions, there are some important issues. One thing is there will be malapposition, there will be under expansion. All this can lead to stent thrombosis and stent restenosis. So final imaging is mandatory to see whether the stent is expanded or not, or it is well apposed or not. So if there is any malapposition or under expansion, we can correct it by doing further balloon dilatation.
So recent studies, especially some of the latest OCT studies, they have shown very clearly persons who underwent a final imaging run, they compared without imaging run. There is a significant difference in the mace rate. Why? Because once you do the final run, you are rectifying all the underlying issues like under expansion, you are rectifying, and malapposition, you are seeing, ensuring that is covered now. And at the same time, any geographical miss, particularly in the landing zone, is there any significant plaque burden, especially if the lipid-rich plaque is there, restenosis rate is very high. Never land in a disease segment, especially with plaque burden more than 50%, and that too in the lipid-rich plaque, where there is a restenosis chance is very, very high. Then, are you leaving any medial edge dissection or intramural hematomas, proximally or distally? Ensure that you are covered adequately. Expansion is adequate. Expansion, always compare with the proximal half with the proximal reference area, distal with the distal reference area. At least it should be more than 80% of the reference vessel diameter. And at the same time, if it is less than 70%, that means under expansion. If under expansion is noticed, assume that there is significant calcium, you are unable to expand it further. But ensure that at least if you are using the OCT, the MSA should be more than 4.5 square mm. If you are using IVS, at least it should be more than 5.5 square mm to get the best results. If these areas are achieved, that is immaterial, because all IVS studies have shown very clearly if you achieve the IVS area, except left main, like a LAD, L6, RCA, their results are much better. So one is having adequate MS area or comparing with the reference zone, achieve that more than 80%. Suppose sometimes very thick calcium is there, it's not possible to get the 80%. But if the luminal MSA is more than 4.5 by OCT or IVS 5.5, that is reasonably very good. It was recommended by the ESC as well as the EBC. So ESC guidelines clearly mentioned you can go ahead with these guidelines. And now IVS showed very beautiful areas. Left main area 14 square mm, LAD 10 square mm, and mid LAD 7 square mm. These areas are extremely good areas. So regarding the LM area, anybody wants to discuss regarding how to gain the luminal area before and after? Anything you want to say? So regarding the left main area, there are two studies. One is Excel and another one is Noble study. So they compared the subset analysis. So they Noble especially 10 to 14 below 10 square mm, they compared with the persons who achieved more than 14 square mm. So persons who achieved more than 14 square mm, they got extremely good result compared to those persons with MSA less than 10%. That means bigger the better, provided within the limits of the vessel wall. So that is the reason always left main is a big area. Try to get, if you are getting more than 10, that's fine. But if you achieve even 14, 15, 16, don't hesitate, provided that is within the limits of the vessel diameter. So take adequate size and expand it very well. Now, if you observe the IVA study, we don't see any calcium nodule. Completely pushed one side, completely flattened. Luminal area is now completely, it's looking a circular, circumferential, circular geometry. And really, it's one of the beautiful images to showcase. Why? Because the IVL and ROTA and ensured the complete modification of the calcium nodule, and we are unable to see any projecting nodule into the left main, and such a big nodule completely disappeared, and it's pushed in flat, completely flat and pushed one side, and we don't see any calcific nodule in the final images, and the luminal area is very good everywhere. So that is the advantage of combined, though cost is more, but in complex cases, that is worth it. So when complex is never compromise. So this is the final image, and you can see the final angio images. Now very well expanded LM stent, and LAD is flowing very well. L6 is absolutely fine. Sir, you can say few final comments, then.
And very well done. Osteal LMC severely calcified with calcific nodule, using various imaging modalities and plaque modification technique. This is a very important case. There is a lot of learning points in this case. How to ablate the calcific nodules, how to do rotablation in a osteal LMC dealer. What is the importance of IVS? What is the importance of areas and expansion? All those things we can learn from this highly educative case.
I hope you can say final few words. Correct.
It's important not only to utilize the imaging, but also a very thorough and detailed analysis of the image which has been taken is extremely important. So the IVUS calcium score is easily 4 in this case because there's also a presence of calcium nodule. So we know that we do need a very aggressive plaque modification. And also, as rightly so done in this case, the IVUS was done after the first mode of plaque modification. So we realized that it was not adequate. So we had to do a combined strategy, or further plaque modification was necessary. And then once we were comfortable with the plaque modification, the stenting process was much easier. And as mentioned, the areas are very good, the areas we have gotten. So the patient should have a good outcome.
Aparajit?
One more important point in this case is patient is having LV dysfunction and she has presented with failure. So always whenever going ahead with the complex PCA, think of MCS support, be it IABP or impeller, ECMO, anything, whichever they are affordable. Better to think about the MCS, then go ahead with the complex PCA. With whatever the possible modification devices available, you utilize in that patient for the better outcomes.
Yeah, both of you can say.
Yes, in this case, we have means we can summarize this case in a simple words, like we have used 3Ds in this case, means we have defined this case nicely, we have defined the lesion morphology very nicely. Then we decided what to do with the plaque modification with calcium, and then we nicely delivered the treatment. So 3Ds we have done nicely here, defining the lesion, deciding the treatment, and delivering the treatment.
And instead of confining to one plaque modification strategy, we can use combination of plaque modification strategies as we have used in this case, and we got the better result.
So at the end of the procedure, again we checked the LVDP. LVDP was 14. Then patient was stable and not requiring even ABG we repeated. ABG was absolutely fine. Lactates were only 1.1. So then we removed TPA on the table and IABP was removed, and we used angioseal to seal the local access site. And final takeaway points, IVA helps in identifying the plaque morphology, choosing the right device, and efficacy of the plaque modification, and easy to adequately modify it or not. And usually, if the calcium is severe, it requires a combination of the devices. Rota with IVL or laser with rota combination. So initially use laser, subsequently you can rota or orbital combinations or orbital with IVL combinations. So the different devices you can use it, and definitely that is going to be helpful in modifying more adequately, and always implement MLD max algorithm for providing the better outcomes. So and then patient discharged 3 days, within 3 days recovered very well. We discharged on the third day, I think fourth day we have discharged. She came for follow-up about 10 days, just today only, that is on the 10th day. And patient is absolutely doing well without any difficulty in breathing. She is on her own. That means it's a boon, 85-year-old lady without any disabling symptoms. If she's living, absolutely nothing like it. And lastly, to say a few words about my coronary OCT. Yeah, keep it. You
Coronary
can say final
OCT,
conclusion also.
OCT, this case-based representation by Dr. Sridhar Kasturi Garu. This is a wonderful book. It is available on Amazon also. There are a lot of books I have seen in the internet, but I have seen this book is very exemplary. It is very lucid, case-based approach, each and every aspect of OCT, whether it is calcific nodule, identification of calcium, this thing, thrombus, red thrombus, whatever you want. Each case, it nicely, it's every interventional cardiologist must possess this book. It is very, very, very lucid way of writing. Very nice book.
Thank you very much, sir. And Kavya, you can say a final conclusion and you thanks, vote of thanks. You can say on behalf of the institute.
So, on behalf of KIMS Sunshine Heart Institute, a very heartfelt thank you to everybody who has logged in for this session. And we will be coming up with more such cases, because We find it is very important for all interventional cardiologists to know about the available imaging modalities and how to interpret them. More so, how to interpret them so we can give the patients better outcomes and how to use plaque modification adequately. So thank you so much for logging in and watching our live case.
Thank you all of you. Okay, you can check out.